needs to understand why is there still an ongoing debate about this rather simple topic in the literature. It's a very common problem. I have nothing to disclose. I just want to take you through a couple of surgical options and the clinical evidence that supports it or not. You all know that a Chiari malformation is identified by caudal displacement of the cerebellar tonsils, and we now learned that this is likely due to the fact that the P fossa doesn't develop, is hypoplastic. It somehow impairs CSF flow, which you can see on the sinus sequences quite nicely, and it often comes associated with a syrinx in the cervical spine or lower. So the current diagnosis of a Chiari malformation is really an anatomical or radiographic diagnosis. The cutoff is usually at 5 millimeter, but there may be more symptomatic patients with a much lower displacement. Now, for the purpose of this talk, we just want to talk about Chiari 1 malformation, which means the patient has one problem, which is the displacement of the tonsils and associated syrinx in some cases. These are most often seen in women, usually in Caucasians, and prevalence may be as high as 1% in the population. You may be in for a surprise. I did this young female who showed up in my OR, and I honestly hadn't looked at the films well enough, but she came with craniocervical junction abnormality and atlas assimilation, which made the surgery significantly more difficult. So I've listed for you here the associated bony abnormalities from an anatomical perspective. And what you should be looking out for is atlantoaxial dislocation, possible atlas assimilation, maybe clipal file anomalies, but especially instabilities of the craniocervical junction. And Arthur Girl is usually advocating for a completely different approach for this patient population. In rare cases, you find other intracranial diseases, which we can skip for today. So what are our treatment options? I just want to talk about posterior approaches today. And the idea is what type of decompression can you offer? And I skipped a part of the fusion for today. So in my mind, there are basically three options for a posterior decompression. It can be a bony decompression alone. It can be a bony decompression plus a duroplasty with or without arachnoidal release. And the third option is to do a bony decompression, do a duroplasty, and take part of the tonsils out or shrink them. All of these are done in various positions. It doesn't really matter. You have to get in from the back. Treatment option A, if you think about a bony decompression only, the literature says you should get a decompression about 2.5 by 2.5 centimeters. Don't decompress too much. Your cerebellum may be sagging down towards the spine, and you end up with more postoperative problems than you had preoperatively. Most importantly, do not forget to cut the dural band that is formed at the junction of the cranium and the spine. This is especially suitable in children. Now, treatment option B, you add in a duroplasty. So you take out the bone, you open up usually the dura in a Y-shaped fashion, then you see your intracranial contents. Some colleagues stop at this point and they just put a dural patch on top of it. I think a slightly more complex version would be this one, where this is a patient in the Concord position, so images are upside down, where you have exposed the dura. Here you see the tonsils squeezed into the canal, which is now caudally up. And what you should do is an untethering of the arachnoid at this level. And if you want to, you can add in the tonsillectomy at this stage. Now, more recently, there's a trend towards minimal invasive surgery. Anything that is minimal invasive seems to be cool, but it's unclear whether there's really a benefit of this in the literature. It has the advantage of a small incision. You need fluoroscopy through it. You can go through a tubular tube. This one would be a matrix tube. And here I show you how this looks during the case. One of my colleagues at Hamilton is actually doing this. You can identify under fluoroscopy C1 and drill out the bone. Then you have created a C1 laminectomy, and you just slice the dural band in the middle to achieve a dural release. And there may be patients that do benefit from this procedure. The question is, what is actually most effective here? And since this is a meeting on complications, I want to explain to you, I think that question has been answered. So this excellent meta-analysis looked at exactly those three groups: bony decompression only, group 1, group 2 with duroplasty, group 3 with tonsillar resection. And they pulled from the literature 1,200 patients that were suitable for this particular study. And not surprisingly, 80% of patients do benefit from a decompression, but surprisingly, 20% do not. So it's a pretty high failure rate, and actually 6% of patients got worse. Now, if you look a little bit more in detail, and you look at the three groups, there are three take-home messages. Patients with bony decompression alone did clinically significantly worse. They have less success rate, they have more frequently reoperations, they have the same amount of complications, and they have more takebacks for headaches. There was no statistical difference between those patients undergoing a duroplasty and those who had a duroplasty plus a tonsillectomy added. The one thing that was better with tonsillectomy was that patients with the large syrinx recovered faster in their syrinx on radiographic follow-up. But if you look at the complication profile, the answer is quite clear. Surprisingly, 20% of the patient population of all techniques had a complication. Half of those were medical, DVT or meningitis. The other half was actually surgical. And it was absolutely stunning to me to discover that of the 10% complications, 6% of patients had a new motor deficit, 12% of patients a new sensory deficit post-operatively. And out of those, the group that had a bony decompression plus duroplasty plus tonsillar resection fared the worst. So how do I do it now? I just do the craniectomy. I do a C1 laminectomy. I never do a C2 laminectomy because I think you need to maintain cervical lordosis. I always do an arachnoidal resection, and I add a duroplasty with patient's autograph, and we have published this for those who are interested. This is the step-by-step approach. You can look this up later. This is your radiographic outcome. You get a small bony decompression about the width of the spinal canal, and you see a nice CSF pouch forming behind the tonsils. No need to take them out in my mind. Now, Shlomo Constantini has published a nice paper on those patients that have a persistent syrinx that remains symptomatic despite a decompression. I have not done this for the last 10 years, but I wanted to add this in. It's a nice technique to potentially just drain the syrinx if that's the part of your symptomatic disease. So outcome summary, clinical results are encouraging in general. Patients will get better, most of them at least, but results clearly differ based on the surgery performed. Whether you do a bony decompression, you add in the duroplasty, and you take the tonsil out. In my mind, point 3, bony decompression and duroplasty showed significant improvement with statistically superior response rates, and patients had a much higher complication rate when you add in the tonsillectomy. Thank you.